Good afternoon, everybody, and welcome to yet another edition of CCR. Today, on behalf of the Department of Neuroimaging and Interventional Neuro-Radiology, we are going to present a case of aneurysm, which was treated with the help of intrasaccular device, which is a relatively newer technique and has come a long way because of the simple reason that in intrasaccular devices, basically what you are trying to attempt is not to give any dual antiplatelet therapy, because in acutely ruptured aneurysm, the priming the patient with DAPT might be a counterproductive thing. So intrasaccular devices are really useful, but if you go back to the history of the management of aneurysms, it has been really challenging, and a lot of evolution has taken place since the year 1970. The first management was by deploying the detachable balloons inside. That was in 1974. We did our aneurysm treatment almost in 91 and 92 with the help of the detachable balloon. And it used to take a long treatment time, almost one case to 10 hours. Then later on, we had mechanically detachable coils, which were pushable coils. Then we have detachable coils. Then we have the balloon-assisted coiling, then stent-assisted coiling, then Y stenting. The first Y stenting was done by me in 2008. It took me 7 hours to treat that. But today, if you look at the technology and the devices and the adjuvant options that are available, it takes almost 5 minutes to deploy these devices. So it has come a very long way. It has shortened the treatment time, it has reduced the complication time, and also with the help of the intrasaccular devices, you can do not give any dual antiplatelet therapy. So today we are going to show a few cases, and there are follow-up in a couple of cases, and my resident, Dr. Sharik Shah, is going to take us through the evolution of the technique and then finally come. Over to Dr. Sharik.
Good afternoon, and thank you, sir, for giving me the opportunity to present the CCR on the behalf of Neuro-Radiology. So let's go through the evolution of the aneurysm treatment. The first open surgical treatment for intracranial aneurysm was performed in 1931 by Norman Dodd, who utilized the wrapping around the aneurysm. Before that, aneurysms were treated by ligating the artery, the Hunterian method of ligation of the artery. And the first application of aneurysm clip was done by Walter Dandy in 1937. The clipping since then has evolved. And in the endovascular aspect, the first angiogram, the cerebral angiogram, was done by Igas Moniz. And in 1964, Leuwenhoek and Velasquez performed the first successful microcatheterization of cerebral vessels in a PCOM aneurysm. And the breakthrough came in 1974 by Serbin and Co., who introduced the detachable balloons, as Sir said, were utilized for occlusion of aneurysms. And then the major breakthrough again was in 1991 when Guglielmo introduced the detachable coils, which are still used in different forms. And then we had balloon-assisted coiling. It was originally described in the cardiac literature and was subsequently used in the cerebrovascular field, where a balloon is placed around the aneurysm neck and the catheter is placed inside the aneurysm and it's packed. The balloon prevents the coils from collapsing into the main lumen, and with this technique, relatively wider neck aneurysms can also be treated. Then came the stent-assisted coiling, where stent is used across the neck and the coiling. The stents also came from the cardiology, where coronary stents were used, and in neurovascular field, it was Higashida who used the first stent-assisted coiling. However, it was until 2002, the first neuroform stent the first actual intracranial stent received the FDA approval. Then came the advent of flow diversion in 2010 onwards. It was a pipeline for uncoilable or field aneurysmal trial. It was in 2013 that was the first clinical trial that demonstrated the safety and efficacy of flow diversion for the treatment of complex intracranial aneurysms. This is a flow diverter. It is a kind of a stent with low porosity, low profile stent, which is placed across the aneurysm, and it diverts the blood from the artery into the distal circulation and diverts the flow across away from the aneurysm, and thereby helping in occluding. The occlusion is slow. And many flow diverters have come up, and the commonly which are used nowadays are pipeline embolization devices, which have improved in the form of shield technology, Vantage technology, the Silk by Bald, Fred, P64, also known as Phenox, and the Surpass. Most of them are also quite frequently used in our department. And then came the intrasaccular flow disruption. It is an alternative technique in which a device is placed inside the aneurysm, thereby minimizing parent vessel metal coverage. And the technique has emerged as a potential mechanism to increase safety for the treatment of complex wide neck, especially wide neck bifurcation aneurysms. So these are the different endosaccular devices, that the devices which are placed inside the aneurysms. The most common and the most studied is the web, which was introduced in 2010 and has most of the cases in the world have been done with this device only, web. And then the contour, it is the modification. And then Luna, the Medina uncoiled and coiled form, Nextent. These are other endosaccular devices currently being used. So let's start with the cases that were done in our department. There's a 70-year-old female who had intermittent headache, and she underwent an MRI where the radiologist raised the suspicion of an aneurysm in the AIIMS region. Subsequently, CT angio was done, which showed aneurysm in the anterior communicating artery. So DSA was planned to further characterize the aneurysm. So there is an AIIMS aneurysm which is seen in the AP and lateral views and the volume rendered images. So this aneurysm was planned for treatment, and this is the aneurysm in the profile, the working projection. You can see the relatively wide-necked aneurysm, which is not suitable for simple coiling, because if you put the coil, it will come down here and it will block this artery. So this aneurysm, the shape was found to be suitable for an endosaccular device. So this aneurysm was planned for a web device. This case was done only 2 weeks back. So what we did, this is the we put the microcatheter, and this is a small microwire. Along with the microwire, we placed it carefully inside the aneurysm. Remove the wire, park the catheter inside the aneurysm, and this is the cine where you can see the device being deployed. This is the device getting deployed. Again, the lateral view showing the real-time view of the device being deployed. You can appreciate this is the device. And this is the native image, inverted native image, where you can see the device. It has it has the distal tip and a proximal marker. And this is the tip of the catheter, and this is the detachment zone. And before detaching the device has an electrolytic detachment mechanism, but before detachment, we do a Dyna CT, which is a high resolution CT to check the deployment, whether the deployment is exact and the aneurysm has been properly covered. So you can see the device, and you can also see the anterior cerebral artery, which is patent, and the aneurysm is completely occluded. And this is the immediate post deployment angiogram, while you can appreciate the stasis, the contrast still remains inside the aneurysm while there's wash off from the cerebral circulation. So there's a stasis, immediate stasis. And for comparison, I have put a pre-angiogram, uh, pre-device angiogram where there is filling and washout of the contrast. So there's immediate stasis. And this is the post embolization CT. The important thing you can appreciate is there are no artifacts around this device. That is commonly seen in case of coiling and in case of clipping, where we cannot appreciate post embolization changes around the coils or around the clips. But here there are no artifacts. So this is case 2, 75-year-old male, chronic headache, incidentally detected aneurysm, again in the AIIMS region. This is the angiogram showing the aneurysm, and these are the frontal and the aneurysm as seen from behind, where you can see the wide neck aneurysm. This is the working projection. Again, we will take a microwire and with the catheter and park the microcatheter in the center of the aneurysm. Then this is the contour being deployed. So this is before detachment, the native image showing the contour well inside the aneurysm. And this is the post-detachment angiogram showing stasis in the aneurysm. And this is the post-embo CT, immediate post-embo CT. There were no complications. And after 6 months follow-up, you can see the aneurysm has completely disappeared. These are the AP views, and this is the oblique view, the region of the aneurysm. So there's no aneurysm seen. So this is case 3, a very interesting case, a 41-year-old female, a known case of autosomal dominant polycystic kidney disease, presented with multiple episodes of recurrent transient ischemic attacks. MRI was done, which was unremarkable, but the neurologist suggested a CT angio in view of recurrent transient ischemic attacks, and IC stenosis was seen. So angiogram was done where we can see a long segment stenosis in the ICA. In this angiogram, what you can see is that there is something sitting here at the IC bifurcation. This is an aneurysm. So because this is the critical stenosis, so this thing was dealt first, and this is the pre-stenting and this is the post-stenting. Overlapping stents were placed and IC was treated. Then we had the angiogram where we found there were two aneurysms, one on the left side and one on the right side and one on the left side at the MCA bifurcations. So we planned the treatment of the both sequentially. We first started treatment on the left side. This is the left side volume rendered images where you can see the aneurysm with the this is the superior division, this is the M1 MCA, this is the superior division, and this is another division. This division is on the zoomed images. You can see it's arising from the aneurysm, and there is some other locant branch that's arising from there. So this aneurysm, it was planned for flow diversion, but the plan was to place a flow diverter across this segment so as to divert the flow across the aneurysm. So here we go. We place the wire and the microcatheter across this division, place the microcatheter, and then we place the stent. This is the stent being deployed across the aneurysm. You can appreciate the stent and the stasis. This is the stent. So this is the flow diverter on the left side. After 2 weeks, we planned for the right side aneurysm. This is the right side MCA bifurcation aneurysm, and this aneurysm was found fit for the endosaccular device. So we planned the contour device deployment. And here again, we place the microcatheter and the microwire and the catheter safely within the aneurysm. And then this is showing the device getting deployed. This is how the device has now completely deployed inside the aneurysm. Now, this is how the device looks like. This is the zoomed view. It's a cup-shaped device once it's deployed, this contour, and it covers the neck of the aneurysm. And this is the post deployment angiogram showing immediate stasis within the aneurysm. And this is the post EMBO CT, where we have a flow diverter which was done previously, and the contour device. After 13 months, the patient underwent a CT scan. She was hesitant in undergoing a DSA, so we preferred a CT angio, and we can see there is no aneurysm on the left side, as well as the right side aneurysm has also obliterated. So coming to the intrasaccular devices, they are especially used for wide-necked aneurysm at the bifurcation, say at the ICA bifurcation, MCA bifurcation. And we avoid in these situations, we avoid stents. There is no need for long-term dual antiplatelet. It's a very short procedure and a very safe procedure. So advantages are a fluid disruption, no parent vessel component. We don't need to place any metal within the artery. And there's better occlusion rates for wide-necked bifurcating aneurysms, and there's no long-term need for antiplatelets. Some disadvantages, like it can be challenging to size the device to the aneurysm because of limited available sizes available for the device, and it is not the easiest technology to use by every operator. It has a learning curve, and it's still an evolving technology. So what are the features of a good endosaccular devices? It should be safe and effective, easy to use, easy to deploy. It should be easy to size. It should be very visible during the procedure, and occlusion rates should match the already established procedures like the stentings, and everybody should use it. And most common, as I said, was the woven endobridge device. It was introduced in 2010, and it's electrolytically detachable braided nitinol cage. The first one was introduced in 2010. It's a dual layer dual layer, where there's one layer and inside it is the second layer. But these devices were very stiff and very difficult to place. And the technology evolved, and from 2013 they introduced the single layer devices in two shapes: the cylindrical shape, what is known as Web SL, and the spherical shape, the Web SLS. The most common, or 90% of the times over the world, is used the Web SL form. And it improved with the introduction of the small microcatheters. The web devices can now be deployed through 017 catheters, the catheters through which we can do coiling. So small catheters can be used to deploy these devices, and it is a significant improvement. So when not to do web is like if you have to, if it's a partially thrombosed aneurysm, if the size is not appropriate, if the shape of the aneurysm is not appropriate, or if the rupture is at the neck and it is not, we don't think that it's possible to cover the neck with the device. And of course the cost, which is very important in our settings. And if you think there is a need for an adjunct device apart from web, suppose if you think there's a need of a stent or a coil along with web, so it is preferred not to do endosaccular device in such situations. So web safety, it has been proven beyond doubt by multiple trials with very insignificant mortality and morbidity rates. And efficacy is also multiple trials have shown to be very efficient, around 80% educate or complete occlusion rates at 12 months, with only 9% requiring retreatment. So web sizing is a little bit tricky, where what we do is we profile the aneurysm in two waves, in diagonally opposite waves, and we take the dimensions. Suppose we have horizontal dimension B, and in another view as B, and we take the mean of these two. Then for the height, we will take the height on one view, second view, add them and take the mean. So mean width for the devices, the device which we use is mean width plus 1 mm, will oversize in this dimension, and we will try to undersize in this dimension, the height wise. Then once we have done this, then we have a chart which is available, where we can choose the advocate size and the advocate microcatheter that will be used. Then second most common used endosaccular device is the contour, and it's the contour is different from the web in that the web, basically it occupies whole of the aneurysm, as is seen, but the contour, as in the case, it occupies only the neck. It is designed to close the neck of the aneurysm, and it's constructed from DFTs in dual layer conformation. It is shown to have a flow disruptor as well as flow diverter properties. In multiple experimental trials, it was shown that the flow diversion, because of this technology, the braided technology here, there is significant flow diversion. It's fully resheathable, repositionable, and detaches electrolytically. Sizing overall is easier as compared to web. In its unconstrained configuration, it looks like a disc, and once it is deployed, it looks like a cup, as was seen in our cases as well. So the contour sizing is easy because there are only 5 sizes available, and we have to take only 2 measurements: the maximum width and the maximum neck. And with this chart, we can size the contour. And contour, many believe that it's easier to deploy as well as compared to web. So web versus contour, both are almost similar when it comes to morbidity and mortality. They are low mortality. They are safe, effective, and but it's relatively not easy to size the web. It's easy to size the contour, and in experienced hands we should use web, while as its learning curve in contour is, they say, is a short learning curve and easy to use. So take home message is endocycler flow disruptors are safe and effective in wide necked bifurcation, ruptured as well as unruptured aneurysms. Thank you.
Thank you, Sharik, for taking us through this complex topic. Now the topic is open for discussion. If there are any questions, we can address them. These are all. Yes. Cost is close to 7.5 lakhs.
Don't need to put any
I didn't know. In our case, see, the aneurysm, the web is fitting into the aneurysm. There is no need to put any adjuvant device like the coin. But suppose there is a multi-lobulated aneurysm and the neck is not so very favorable. In that situation, we can always change the catheter inside one of the lobule which you think may not be fitting, and then deploy the web, and the lobule which is not showing any stretching, you can put few coils and then. So that is another way of it. Sometimes the web, the neck is too wide for the web to hold inside the aneurysm. In that situation, people have deployed adjuvant treatment like say stent to keep the web inside. But if you ask my personal opinion, if the web is not fitting into the aneurysm, then it's better to do stent assisted. Because again, it's a technique which has come a long way and shown good results. Or we can straight away go for the flow diversion and put few coils inside. So if you want to put a stent and a web, I will say put a flow diverter and put few coils. So that is the ideal. Another question? Shashank? Thank you.